Hi, I'm presenting a case study in driving change from our experience with the Australian Stroke Clinical Registry. A little bit about us. I'm Professor Dominique Cadillac from the Florey Institute, and I'm the data custodian of the Australian Stroke Clinical Registry, and I'll be presenting this session with Nicola Hall from Logan Hospital. I'm going to start by just giving a bit of highlights of stroke care in Australia. One person has a stroke every 19 minutes in Australia, and it is a leading cause of death and disability. It was estimated in 2020 that over 450,000 people were living with stroke, and 1 in 4 of these are under 55 years of age. We have effective treatments that we can provide people with stroke to make sure we can reduce their chance of having disability or dying after stroke. However, there are challenges in implementing these evidence-based treatments, and not all hospitals perform the same. So I'm going to talk about the way in which stroke care and continuous quality improvement work hand in hand to ensure best practice management within Australia and ensure that where there are issues or gaps in practice that we can address those directly. First, we have evidence-based clinical guidelines that provide the recommendations for treatment. We also have frameworks for standards of care that we expect in the hospitals to be offered, as well as care standards by the Australian Commission on Safety and Quality in Health Care. We have ways of reliably collecting data through our Australian Stroke Clinical Registry and performing analyses so that we know we're comparing like with like. These data can then be used for quality improvement activities, and Nicola's going to talk about a case study from her hospital. What this then leads to, this virtuous circle of guidelines, data collection, quality improvement activities, is improved care and better patient outcomes after stroke. So how do we use data to drive improvements in hospital? One of the big concerns is that, firstly, people are aware when they have stroke symptoms that they need to get to hospital quickly. Around 1 in 3 are coming to hospital within the window for thrombolysis, which is around 4.5 hours. The other issue is that we're not really seeing shifts in the delivery of intravenous thrombolysis to our patients, and this is a clot-busting drug that, if given early, can really reduce the effects on immobility, unable to speak, or having other problems after stroke. And what's a real concern is that we lag behind other countries in the delivery of this treatment. When people get to hospital, we're very slow at delivering it. We don't achieve treatment within 60 minutes of hospital arrival as often as our colleagues. So what is it that we can do to improve aspects of care like intravenous thrombolysis? So we established the Stroke Clinical Registry in 2008, and it follows best practice standards, including opt-out approach and a waiver of consent for people who die in hospital. This means that we have as much information on all patients and we avoid selection bias. We have an agreed national minimum data set of priority indicators, and we collect these on all consecutive admissions rather than snapshot audits of medical records, which have their place as well. But having consecutive data on a minimum data set really means that we can track well some of the priority measures that we want to deliver in Australia. The other thing that we do is we collect patient follow-up surveys, whether their quality of life has been impacted, whether they're still living at home, whether they've had to go back to hospital. And we also link our data to the national death records so that we understand survival relationships as well. How are we going with the registry? Well, at the moment, we have 86 hospitals approved to collect data. We have to go through an ethics approval process. And we have over 112,000 episodes of care recorded in this system, mainly from hospitals on the eastern seaboard. And we have followed up over 50,000 people who are living in the community with stroke. We now use the data to inform what happens in usual care. So we know that around 8% of people die in hospital, 1 in 4 will go to inpatient rehabilitation, and when we collect our data of people living in the community, about 1 in 4 are free of disability. However, 1 in 2 report problems with mobility, pain, anxiety and depression. Access to stroke units is very good in our sample of hospitals, but there are differences depending on access to thrombolysis, depending on where you live. But does it make a difference? Do delivering these bundles of evidence-based therapies work? Well, it does. This graph highlights the dose-response relationship if you're to get none, 1, 2, or 3 quality of care indicators. And if you get all of them compared to none, you have a 70% reduced hazard of death and an 18-point increase in the quality of life. This is massive. So how do we use the data to drive quality improvement? We use it through the Plan, Do, Study, Act methodology, plus external facilitation that is supported by the work we do in collaboration with Monash University and the Stroke Foundation. And we help sites to agree on action plans to address areas where they're underperforming. We illustrate areas of underperformance through these data feedback graphs where we highlight a particular hospital against the performance of other sites, which is designated by each of those bars. And then we also highlight what the achievable benchmark is from the hospitals that provide best practice care most of the time. In the state of Queensland, we were able to use and look at the impact of financial incentives and facilitators to help with that quality improvement practice cycles. What we found was, although financial incentives created the largest shift in practice for accessing improvements to stroke unit care, providing the Enhanced Stroke Link program as part of it with the external facilitation where hospitals were provided support to create action plans and address practice issues still led to an overall change of 18%. I'm now going to hand over to Nicola Hall from Logan Hospital in Queensland to present a case study of how this type of activity works. Thank you.
Thank you very much for that background and introduction, Dominique. As you mentioned, I'm going to be presenting a case study from Logan Hospital and how we've used the information that we've gathered in the Australian Stroke Clinical Registry. So following the guidelines for reducing variation in care as well, we selected a priority area for assessing and reporting this variation. And we became aware through some of those processes that Dominique mentioned of a less than optimal blood pressure lowering medication prescriptions on discharge. And this is just one aspect of the secondary prevention that's really important for patients. We know that when patients are put on these medications when they're discharged from hospital, they have a better chance of continuing to take them and therefore a better chance of reducing their rates of having a subsequent stroke. So we identified how that clinical variation would be assessed. We had data pertaining to our blood pressure lowering medications through the Australian Stroke Clinical Registry. And we saw these things being presented to us at forums. So the actual process of care certainly aligns with a minimum standard of minimising stroke secondary prevention. And so we went on to really dig down and measure how this variation was and review our performance. We did this both internally and externally. So those external processes came from the Australian Stroke Clinical Registry reports, presentations at our stroke forums. And from that, we were able to actually dig down into the specific patients. We were able to identify which medical treating teams were caring for them and where the variations were. So this was just, all these graphs represent part of the picture. And then, as I said, there was a really in-depth analysis. So we went through that and we explored the reasons for that variation. And it was really interesting. We identified that the process provided us an opportunity to support the data collection, and I was very involved in that data collection, and I realised that there are opportunities to not be quite so purist about things. And one of the things that was identified that while we were saying no, a patient wasn't being discharged on these medications, in actual fact, there was a contraindication for it. They either had a low blood pressure or there was some other indication that it meant they shouldn't be. What this highlighted for us was our documentation wasn't really reflecting that. So we did a lot of work on working with the clinicians who document to improve that documentation so that then we could identify who were had contraindications. The data was really, as I said, broken down right to the treating team level. So then we need to do that feedback. So our processes to improve that care and embed those changes, they included the data being presented to the medical consultant teams in a de-identified way collectively. And the interesting thing was most of them wanted to definitely engage one-on-one. It gave the medical teams who were following the processes really well the opportunity to celebrate that. And it also gave us the opportunity to work with the teams that probably weren't quite as diligent and not so much with their processes of care, but particularly with their documentation. So all of that improved. We've had provide ongoing support for our medical teams, and as the clinical nurse consultant for stroke, I send out a welcome email with every rotation to registrars and residents, introduce myself as an ongoing resource for them, and also just highlight the specific aspects of care that are particular to stroke and strongly recommend that they access the national guidelines. And as I said, am available for their ongoing support. So we continue to report those activities and monitor that variation. And I'm very pleased to say that we utilise our quality improvement activity registrars. We have a dashboard and we present to our stroke steering committee. We have good governance in the hospital. And the findings and outcomes are shared to the whole hospital organisation through medical grand rounds. And that's only one aspect of the processes of care that we've analysed. We've analysed a lot, and obviously we only had time to present one case study. So I hope that was informative for you. And if you need any more information, please contact the Australian Stroke Clinical Registry. Thank you.